Welcome everyone to the weekly ARMID COVID-19 virtual town hall. We'd like to thank you all for taking time out of your evening to join us for what's to be another very informative event. Just some quick housekeeping here for you. This is a professional environment and we ask that everyone remain respectful towards all participants. Webinar is being recorded and will be published at a later date on our YouTube channel, as well as a link provided on our website. A quick reminder to everybody who hasn't participated yet, you can see and hear us, but we cannot see or hear you. This webinar is best accessed through a computer utilizing the bottom bar to submit your questions through the Q&A function, as well as the best viewing option is to fit to your window. Tonight's moderators include Megan McCabe, ARMA's Deputy Director of Government Relations, as well as myself, Damian Johnson, ARMA's Director of Communications. And our panelists tonight include Dr. Elisa Chapital from Mayo Clinic Phoenix and Dr. Bruce Bethencourt from Dignity Health Medical Group, Dr. Ross Goldberg, ARMA's President, and Libby McDaniel, ARMA's CEO. And at this point, I'm going to pass it on to Dr. Goldberg to give a quick ARMA update before we move into our guest panelists.
Sure. Thank you again, Damian. Welcome everyone again. Thank you for spending an evening with us like we do every week now. I'm going to be very brief. There's no massive update from today, which is always, I guess, good. There are, as we know, the stay-at-home order is kind of being released this week. So what I ask actually of all of you is to keep on providing us with input and information about what you're seeing and experiencing so we can make sure we continue to lobby on your behalf and advocate on your behalf to the relevant organizations. And that's all I'm going to say because we have two very talented people on the line that you need to hear from them, not from me. So I'm going to stop now.
Thank you, Dr. Goldberg. Dr. Bethencourt? Still muted there, Dr. Bethencourt.
Okay, I think I'm unmuted. Thank you very much, Dr. Goldberg. Do I have the ability to change the slides?
If you just want to let me know and I'll do the change for you.
Okay, we can go to the first slide then. Thank you. Or the next slide. So I just want to review for everybody kind of what we've gone through on January 26th. First person was identified with COVID-19 infection. This came from an ASU student that had visited China. By March 5th, we had 5 cases. By March 11th, WHO declared an outbreak of pandemic. By March 16th, there was a mistake. Both these next two, both 16th, Governor Ducey declares closure of educational facilities to all schools. Again, restrictions of gathering and stay-at-home orders given. March 21st, order banning of elective surgeries. And March 24th, the first death in Arizona. Next slide. So that really put us in at least a dignity. Next slide, please. Next, okay. That really put us into a mode at dignity of really somewhat expecting something was coming, but didn't know the value of it. The hospital had their issues to deal with, which we followed. But the medical group had to focus on, the changing operations and developing policies and procedures for safety of staff and patients. At the same time, they had to be, how can we care for the patients? They have other needs other than that are related to COVID-19. So by March 14th, we developed screening stations for all of our primary care. We had to quickly come up with an algorithm that would to be implemented to convert virtual face-to-face visits with virtual visits. So our call center and our clinics quickly utilized that algorithm to move on to rescheduling of patients that could be attended to by virtual visits, but being able at the same time to identify patients that really had to be seen. Even if the patients had symptoms of consistent with maybe COVID-19, they're probably best attended to at home or through a virtual visit. But those that had severe symptoms had to be seen to determine whether they need to be hospitalized or not. So this is all within a few day period of time. we developed or started an incident command center for the medical group only, which by itself is something we weren't used to or weren't prepared for, but it quickly became evident what we needed to have to be able to coordinate all the care we were providing. So we moved from virtual visits, separating those from virtual visits from face-to-face visits, developing for those that need to be seen, even though it wasn't related to COVID-19, to be seen in the morning, those that could have symptoms of COVID-19 to be seen in the afternoon, and then moving a lot of the primary care to a particular clinic so they could be seen there and not co-mingle with the other patients. We developed a bi-weekly communication hub with all of our providers and staff, educated providers and staff on how to don and doff PPE. Had to educate, we didn't have enough PPE. So actually the chief of surgery, Dr. Galliano, found the fabric and found a seamstress or a group of seamstress to develop the gowns and masks for our utilization, and actually it is still doing so. But also we had to worry about our not only our patients, but also our providers, and when they came home, and not to infect their family. One of the interesting things that was done by St. Joseph's Hospital, I thought was very unique, and was surprised and have, just flabbergasted that they actually set up a grocery store for staff to purchase groceries prior to going home in the evening, so they wouldn't have to go to a grocery store. Something I'd really never heard of, but quite amazing. The whole idea for us to change how we do things, to flatten the curve, to protect our patients and our staff from getting COVID-19. Next slide, please. So the issues around what we've done with our providers, we had, and with the staff also, is to have bi-weekly meetings that I've conducted for they're just 20-minute meetings to update them on everything that's going on, any new proclamations by Governor Ducey, plus the changing manifestations of the disease. So the skin manifestations that were not easily identified at the very beginning of this. We went from skin rashes from typical urticaria, morbilliform, and vesicular rashes you might see with frequent viral illnesses, to something more specific for acral ischemia and libido reticularis from inflammatory cutaneous vessels that was caused by COVID-19. Unknown in the beginning, pretty well known now, but new to our providers. The sudden complaint of loss in taste and smell that would help providers identify COVID-19. And actually, its reports have shown that in many cases, this was a presenting symptom. And also to identify and to educate our providers on the association between COVID-19 and the pediatric multi-system inflammatory syndrome, much like Kawasaki's disease. So our pediatricians were aware of that. And also the ongoing hypercoagulation associated with COVID-19 actually has been described as diffuse pulmonary intravascular coagulopathy that's really causing the depth of the disease, the severity of the disease, and in many cases death. And then also having to educate our providers on the antiviral medications that could be used for this, trying to re-educate them on viral replication. And I mean, I remember, I had to re-educate myself on viral replication, RNA viruses, and how they work and where these medications could actually work. Educating on the hydroxychloroquine and azithromycin, which has been given somewhat of a bad rep, but educating them on, if they already used that in the beginning, on QT prolongation and prevention, and remdesivir, and how it works and how it could be used and when to use it. So these are a lot of things, just an educational piece for our providers, but keeping them up to date on what needs to be done. And I have to admit, this has taken up, I would say, 50% of my ordinary job. And I can only appreciate, having been in private practice for 23 years, how this would have affected me when I was back in practice. So I really appreciate the Arizona Medical Association. All they're doing is to help educate the physicians of Arizona. Next slide. So the other thing is serology. Everybody asked the question, and I personally, to me, it was quite evident. Hey, we had the serology. We could know who already has the antibodies, and they're immune. They can go on. Don't need to worry about it. That's not quite the case. There are as many companies out there, many that are out there, and what we really need to find is, what is the accurate sensitivity and specificity of this? So what are the true positive rate? What is the true negative rate of this? And the other problem with all this is there's a lot of, the combination of IgG and IgM testing, there's a potential of a lot of pre-activity with other coronary coronaviruses that are not as deleterious as COVID-19. So, and the poor specificity of IgM. So, IgM doesn't develop for at least a week, so you can't use it for acute diagnosis. But we really need to figure out what antibody testing is going to be appropriate, because if we have to rely on this, you may have to rely on this testing. We need to know if you have an IgG that you think imparts immunity, does it really impart immunity? So that's the things, it's going to take months to figure that out. So just a bit of caution there. Next slide. So now we shift gears all of a sudden. As of the 15th, we can kind of open up things and reopening clinics or broadening who we see in the clinics. We have to be cognizant of, we have to have sick clinics, well clinics, impart, universal masking. We have to, source control for our patients and our staff. Social distancing, that is a huge one. To keep everybody's, if you think about it for a second, 6 feet apart, and you've got a waiting room that's 10 by 10, how many patients can you put in the waiting room to be seen? If you're seeing patients every 15, 20, or 30 minutes, whatever it might be, how many can actually go in there? And how many patients do you need to attend to? Because we have issues with COVID-19 symptoms. We have patients that have heart failure, diabetes, asthma, other issues that are unrelated, cancer prevention, annual wellness visits that have to take place at the same time as attending to patients that may have COVID-19 or symptoms, related to that. And how can we balance that? And I think the best way in some form is to, what I'm looking at is to alternate a face-to-face actual visit with, with a video visit, or with a video visit, and alternate that way. So the waiting room is not full, but I'm working on right now what patients can be seen, in a visual visit that's appropriate, and what patients need to be seen face to face. And so I think that's a new thing coming. Again, I talked about screening and testing of patients, and we're going to have to broaden the hours of our clinics. So, and at the same time, make sure that our clinics are clean and protect patients and staff from the infection. Not to mention, I didn't before, not only do patients have to be screened, but staff has to be screened. Do they have a fever? They may not offer up symptoms because they need to work, but if they have a fever, we probably need to send them home. So we need to monitor them. We need to keep them safe. We need to keep the patients safe. Next slide, my last slide. And the other is elective surgeries. Oh my gosh. So the American College of Physicians have come out with a 4-step kind of COVID-19 awareness. So what's in the community, what's going on, what's the curve doing, preparedness for elective surgery. So do you have enough PPE? Do you have enough ventilators? Do you have that? Patient particular issues. And then, the issues of, and as they talk about the American College of Surgeons, on this model. So if this patient is an elective surgery, that's going to be a prolonged surgery and the patient's going to be on a ventilator for 2-3 days afterwards, maybe that surgery could wait a while. And then delivery of safe, high quality care. So I think the American College of Surgeons have put out a module on that is, I think is not only, it really sets the tone for what's appropriate. It gets away from the good old thing, the good old boys of, oh, I'm a big admitter here and I want to do all my elective surgeries no matter what they are. What do we need to do first? What is second? What is third? I think they've done a great job with that. And then pre-op screening of patients. So screening them for symptoms of COVID-19, bringing them in, doing functional stats with DOSI or NSQIP, doing the basic labs, but testing them for COVID-19. And once you test them, quarantine them at home until the time of surgery. And if it comes back positive, the surgery gets canceled. But a lot that's going on. It's very fluid for everybody. I don't think anybody has the perfect answer, but I do know that there's so many people trying to do the right thing. I just appreciate you giving me the opportunity to share with you tonight.
Thank you, Dr. Bethencourt. We'll go ahead and jump right into Dr. Chapitle's presentation here.
Hello, I am honored to be here. I haven't been doing much, and so for the past 4 months, I haven't seen anyone, so it's nice to see people outside of my organization here. I do want to start off by saying that I am happy to receive any emails regarding some of the information, some of our protocols. I think that's the whole point of ARMA here, is to share information. And during this time period, I think that that's what we've been doing at a hospital level. My email is my last name, so Chapital, which is kind of like capital with an H, dot first name, Elisa, at mayo.edu. So last name dot first name at mayo.edu. So we'll go ahead and turn to the first slide. I have just a few slides. And like I said, healthcare institutions and hospitals have been working extremely hard for the past 4 months. And one of the things that you all need to know is that we've been working in an unprecedented manner. We've been working collaboratively. You'd think that we always would be, especially with an organization such as this one. But we've been meeting, the CMOs and CEOs have been meeting 3 times a week to share the best practices. And I want to take this time to give a shout out to Margie Bessel at Banner, Keith Frey at Dignity, and Stephanie Jackson at Honor Health. They've been really leading this, and it's been really wonderful to be able to communicate and really understand what was happening at the hospital level, particularly in Arizona. Because COVID-19, when it was coronavirus, was of the utmost concern to all healthcare administrators from the very beginning. Anytime people are getting sick and requiring hospitalizations, you can believe that hospitals are watching the news and trying to figure out what to do. So way back when they were building hospitals across the ocean, we were patiently watching and keenly aware of what the World Health Organization and CDC were saying, but the virus appeared to be moving faster than those guidelines. And so we as healthcare institutions had to look at our facilities in an entirely different way. Many people, like Dr. Bethencourt was saying, pulling together these incident command centers wasn't really easy, especially when we had been building these command centers for something like a natural disaster, or a flood, or a burn. And so we had to come and do things a little bit differently, so it was really good to work together. And so there was no playbook for this. And so information was changing quite rapidly, and we didn't have really any evidence to proceed. So we had previous history of viral illnesses, we had some expert opinion, we had deductive reasoning, and in the end, I think everyone moved forward with just practical decision making. And so now there are a bunch of pundits out there saying, they knew that we would be right here, but I don't think that they had the data, because we didn't have the data to predict where we were going to be. And I'm really proud of Arizona as a state and as a healthcare collaborative, because I think that We've limited the number of people who have died from this disease, and I think we're continuing to provide the best care possible. So we'll go on to the next slide because this was titled, "What are the best practices and protocols out there?" And I just have 3 best practices out there that I can say if we were going to tackle another pandemic, and hopefully never in my lifetime. We were laser focused on patient and employee safety from the very beginning. So that practical decision making was all based on keeping people in our facilities safe. 2 would be creating white space, taking the time, pausing so you could prepare. And then 3 was really being transparent and communicating throughout the process. So we'll go to the next slide. How do you keep patients and employees safe? You'll see this slide, there's a ton of information on here. Most of it's not new for many of you guys. Many of you guys were doing these things in your facilities, in your private offices, but we had one big audacious goal here at Mayo Clinic, and that was we didn't want a single person in our facility, employee or patient, to contract COVID-19 because that was preventable. So from lack of PPE or lack of any of our safety measures. And so we were extremely conservative in the very beginning, pulling people out of practice and minimizing people from the very beginning. And it really depends on your phenotype of your organization on what you can do. Mayo Clinic is an employed physician model, and so some of the unique things that we were able to do back in February, because we had our incident command center up in January, we actually limited travel for our employees right at the beginning. So you guys may have heard of some people getting exposed at national conferences. We stopped all of our employees from going to national conferences, from teaching at visiting professorships. We weren't able to limit private travel, but we limited educational travel and work-related travel and brought people back into our institution. The other thing that we did was we limited some of our learners. So our medical students and nursing students and some of our research assistants, we actually moved them out of the practice at that time. Our residents were still part of this, but we needed not to make any errors in the very beginning, and we had no idea what this was going to be like. And so important with some of these things is, 1, the cadence, and 2, sequencing the things to do. And so the things in the red and the yellow were really some of the things that we started in the beginning, and many of you guys did. So universal masking, cohorting, all of these things. But we were able to get testing up very early, and that was some MacGyver work from our lab, Department of Medicine and Lab Pathology. They jury-rigged one of our Epstein-Barr virus machines and got FDA approval, and so we were able to test very early, and we were very liberal with our testing, which apparently now everybody needs to be tested with all the symptoms that they're throwing in. But we were very liberal. And the other thing we did along with Banner was we did drive-through testing very early. I think they were right there among the first, moving people outside of our facilities, and I think that was important for safety. A couple of other things, teleworking, EVS, all of these things we can talk about, but what everybody is looking at right now is what's in the purple. What do we do with serologic testing? Do you start testing all your employees? When is there going to be a vaccination, and these types of things? And I'll allow those to come out specifically for questions. So the next slide shows number 2, which would be creating white space, stepping back, giving some time for everybody to learn, like Dr. Bethencourt said, teaching people PPE, doing fit testing all over again, all of these things that we needed to do. And what we did in the beginning was we started ramping back on the practice very early before the executive order. So we saw this coming. Those numbers, those dates that Dr. Bethencourt gave where there were some positive results in the state, we actually decreased our outpatient and elective care by 10%, and then by 25%, and then the elective order came and we actually closed our outpatient clinics. So that obviously came at a cost, but what that allowed us to do, and you can see on the next slide, is just one example. We created these meticulous, comprehensive surge plans within our organization for hospital internal medicine, critical care, and ED, the areas that we thought would be impacted by COVID-19. We didn't know how many numbers of patients that we were going to get. And so within these areas where we were able to figure out where we would put additional patients, we also needed providers. So all of those outpatient providers that were a little bit far from maybe medical school, we brought them into the hospital and started training them. They started shadowing HIM. They started working in the emergency department. Our CRNAs worked with respiratory therapy and with our APPs in critical care, so we put everybody to work to familiarize them with what was going on. These outfilled areas that we built, we wanted to make sure that people who were receiving care within our hospital would receive the same level of care in the outfield. So beds, IV poles, IT, EHR. It took a lot of work to do that. But again, like I said, patient safety. If we were going to have these patients in our facility, we wanted the best possible outcome, and we wanted our physicians and providers to be prepared. And this took a significant amount of work. And so again, like I said, if anybody wants any of this information, I'm happy to send it to you, but hopefully we won't need it at all. And then the third point, which would be the next slide, is the communication, transparency. We communicated and communicated and communicated some more, and I can show you just a little bit of the things on the next slide. Like Dr. Bethencourt said, we had, biweekly town halls. I had daily leadership updates where we did Zoom conferences with all the leaders in the organization and answered question after question. We sent out daily updates with status of what was going on in the Valley, and now that we have access to what's going on in the other hospitals, we're able to push that out because the physician community out there is very astute and wants the broad data so they can interpret it themselves, and so we're still doing that information. We put stuff on our email and then our portal, so we pushed it out to all of patients as well. We have a dedicated nurse line still in place 24 hours a day, and we opened up that command center, like I said, in January with open phone lines. Despite all of that, people still say, I need information, at this time, and I think it's really just because we still don't know what is going to happen. So I guess on my last slide, I can tell you where we are right now. We are trying to shape the inpatient demand, which is a little bit hard because we don't control what comes in through our emergency department. We do know that the volumes universally are still lower across the state. It may change when that stay-at-home order changes, at the end of this week. But we're trying to balance our demand with our inpatient capacity because we're a little shop. We have 300 beds, 5% of the capacity here in the state, 5% market share. But we have this backlog of elective care and semi-urgent care that we just postponed, and we have to take care of some of these patients. But we don't want to fill up our hospitals and then end up in the same state as we were before, although we do have these plans in place. And so we are still managing that on a day-to-day basis. We need to be able to surge to 25% in a short period of time, and so that is something that we're managing. So we continue to capitalize on some of the lessons that we've learned managing patients with telemedicine, telehealth, phone calls. And actually, I have to tell you, in the very beginning, we've been trying to do this for about a year, and our physicians and providers didn't really like it, and now I think people really like this model. And so as we bring patients back into our facilities, we're doing a combination of both of those. But again, those three priorities of keeping people safe, as we bring people in, still limiting, the number of visitors in our facility and the number of patients at one time so we can respect social distancing, being transparent to our providers so they feel comfortable and safe. Caring for patients is important, and we still are maintaining a little bit of capacity, a little bit of that white space, even though financially that's not a great thing to do, but we need to serve our part and be a community provider should COVID-19, surge again in the next coming weeks. So those are my lessons learned at this time, and I'll turn it back over to Libby, Damon, and Megan.
Thank you, Dr. Chapital. Yes, at this time, we're going to open it up for questions from the audience. We'll go ahead and get started with a question that was submitted prior to the beginning of tonight. I just want to remind all the participants that you can submit your questions through the Q&A button under the control section. We'll go ahead and start off with the first question submitted prior. I have heard some practices are having patients sign a consent to be seen during the COVID pandemic for medical care. Is this something that either of you would recommend?
Oh gosh, we are not doing that at all. We are doing active screening of all patients and visitors, and in fact, they end up getting screened a couple of times. So they get screened as they set up the appointment, and if they have symptoms, then like I said, we're being very liberal with testing, so we try to test them. They get screened at the door as well. But if we do identify COVID-19 positive patients, and we do have those, we are trying to continue to care for their needs, but through video visits if we have to. But there are a lot of complex care patients out there who can't do a video visit, so we're setting up one area of our organization where we will bring in those patients on an outpatient basis, but no consents.
Well, the only consent that we're getting is actually a consent when we're doing a virtual visit, asking permission for the patient to have a video visit. We're asking that for that permission, but no other. But you have to remember that the governor has invoked the Good Samaritan Act that for any physician providing care that has the best intentions, unless it's some extreme negligence, that they're not going to be held. So I think having a consent signed, other than for having somebody under audio visual, I don't know why you would do that, because I believe you're protected.
I will say, just funny enough, we had, as with the elective surgeries coming back at my institution, we have a separate COVID-19 consent related to surgeries, not for overall treatment, but just the warning that during a pandemic, things can change and there's that extra risk. So there's two consents we get for operations, but yeah, we're also, the only thing we're getting is consents for telemedicine visits, but which we have to document. But otherwise, yeah, I don't know of anyone who's doing overall consents.
Great. Thank you to our panelists. I'm going to follow up with another question that was submitted in advance, and then we'll turn to the Q&A section for the live questions. So a question from earlier is, some surgical organizations have released recommendations for facilities to consider when beginning elective surgeries, including tracking of those patients postoperatively to determine the rate of conversion to a positive test. Is your facility tracking this, and at what, if so, what time points, 2 weeks post-op, etc.?
Well, I can give you a little bit of information on that. I have no idea how most organizations could do that. And I don't even really know what the evidence behind that is. It would be just really very difficult. But I can say that we are, because the story of this still is being written. This is a living document. So as an institution that does research, We are planning on testing our inpatients. So if there is a person who has had a surgical procedure, we are going to do some serologic testing on top of our PCR testing, because we test everyone in our institution right now with PCR, RNA swabs. We will be doing serologic testing, and then we'll be doing serologic testing 14 days later, just to really assess the risk to those patients. I think that information will be important in the future, but as Dr. Bethencourt said, right now we have no idea what serologic testing means.
Yeah, Dignity definitely is not testing anyone after. We are testing PCR testing ahead of time, 3 to 4 days ahead of time to get the results back. But the only problem, if you're testing several weeks later, if the patient tested positive, you don't know when they were exposed and what that means. So, yeah, so I don't know anybody that's doing that.
So difficult because the prevalence in our area, Maricopa at least, is relatively low. So you need to do an enormous amount of tests really to figure out what really is the truth. And I think, you know, DHS is trying to do that right now with the PCR testing, but I don't think anyone's doing post-procedure testing at this time.
Thank you both. We'll jump to another question here submitted tonight. This one is for Dr. Chapoteau. How did your providers, nursing staff handle the stress of this? And did you provide assistance to them for this? I'm assuming it's something we were discussing earlier regarding assistance for them.
This should be all about me. I woke up at 1 o'clock in the morning. No. It's very stressful, and I think that people within the hospital obviously were at an elevated risk because all of the information out there was showing that healthcare providers were at an elevated risk for dying from this disease. In some areas, 20% conversion rate, 30% conversion rate, and so people really had to come to terms with the fact that they went into this specialty obviously to care for people, and this is a contact sport, and it was always going to be an elevated risk, but what they needed to know from us was that we were going to keep them safe, and so we tried to do everything possible. Even with that information coming out, we had to do some additional work. We had some sessions that were, in town halls that were administered by our psychology group, as well as our chaplain group, to help people deal with some of the stress. And then we also offered an employee assistant line that was kind of external so people could communicate that way.
Great. Thank you so much. We have another question from the audience. Says, admitting that my organization does not have the strongest financial department, they've decided that telehealth visits cannot be scheduled ahead of time. Looking at your own guidance for your organization, maybe this is a quote check-in, but have either of you encountered this for telehealth or telephone visits, and any recommendations you might have?
We at Dignity, we started off with the very first week after March 24th with telephone visits, as we were moving into, we had 2 platforms that we created with Zoom that was actually confidential, secure, and with Amtel, another organization we'd already been working with, Amwell, excuse me. So we initially started with phone visits and then moved on. And going forward, I don't know how else we can take care of the patients we need to care for, patients that are our responsibility to care for, while dealing with COVID-19 patients and patients with other chronic diseases, and having social distancing at the same time. As far as I'm concerned, there is no other way to meet the needs of the COVID-19 ill or COVID-19 ill and the other needs of the community dealing with chronic disease. And there's other things that still go on. There's wound care, there's hypertension, there's diabetes. We have to take care of those problems. And so the only way to have social distancing, unless you want to rent an auditorium, which is going to cost you even more, that you can do this without some form of telehealth.
I absolutely agree. I think that, there's the financial piece that this person is questioning, and then there's also the provider piece. So it is really important to communicate with your patients, especially the ones with chronic disease, even if you're not getting paid. Because if you have someone that needs you and they can't get a hold of you because you don't do a telephone visit even, or a telehealth visit, they're going to end up in the emergency department. And then that will be a problem. Or they're going to wait, and then that will be a problem because it'll crowd the hospital. So certainly telephone visits are not reimbursed at the same rate as, some of the other telehealth visits. But the governor did issue an EO that did say that telehealth visits and in-person visits should be reimbursed at the same rate. Right now, we don't know how long that will last, but you're developing relationships with people, and it's important to communicate with them. And I don't think sending a letter or something like that is any substitute for hearing from their provider.
And they're going to remember who's there for them.
Great, thank you both. We'll jump into another question that was submitted prior to the beginning of tonight. Data on hospital-acquired COVID-19 for inpatient is lacking. Are you tracking this data? Will it be reported? And are there precautions working, or what specific changes may be needed in your opinion?
I'm not sure. I think all institutions are tracking, the positive test. And I'd have to say, there's been in the very beginning, there was a restraint on how many people could be tested, who could be tested. And I think most hospitals tested patients that were coming in with symptoms, were screening them ahead of time, testing the patients that were patients under investigation. And I think I think all the hospitals in Arizona, I think that everyone is very well aligned with not utilizing too much PPE, testing where necessary. But in the very beginning, we couldn't test every patient that came into the hospital. Now, I have to admit, in the very beginning, if a patient came in with rash and a fever, they probably were not tested. Today they would be, but that's part of learning.
Exactly. This is a living document, just like you said. And I think we don't know the answer to that yet. We do know the incidence in the symptomatic patients that we've tested. Many hospitals are beginning to test all patients, and we're doing that right now. But what's the right time to retest them? And if you do retest them 3 days later and they're positive, does that indicate that they acquired that in your hospital? It's really hard to say. We're testing every 7 days just so we can properly cohort those patients and protect our employees and our other patients. But as of right now, we aren't able to say where people obtain the virus. But that's the reason why we're studying it. Now I think more and more we'll get more information and we're adding serologic testing, but next time, or this time next year, we might know.
Great. Thanks, everybody. Next question from the audience. Are you having challenges to testing at the current time? Any shortages of swabs, reagents, or concerns about future supply chains, since that was an issue in the past?
Well, I would say yes to that. And I think that it's because we don't really know how many tests we'll end up needing should we start getting a surge. So I do know that even in the northern areas, and the northern areas have been just doing remarkable work as well, I have to call them out. They have testing capability at this time, but how much reagent is available, how long we'll have reagent, how many swabs we'll have out there, all of these will remain a concern. We know we have so many days at hand, but we just don't know the length of this, you know, so I would say yes.
Yeah, I think everybody's being very conservative. We at Dignity, we do have a restraint. Antibody testing, whatever's being used, I think probably Abbott has the best specificity and sensitivity, but I'm not sure what that means. But the actual PCR testing, there's a limit, and we don't want to utilize everything we have inappropriately and not have it in the future. So there is some restraint. And we're needing to use it on patients that are asymptomatic that are going in for surgery. So, because that's very important.
Yeah, or patients who are undergoing chemotherapy, or it's just the reasons to test, I think, are expanding, and then the symptoms are expanding. They've added now just about every symptom that people come in to the emergency room for: headache, nausea, vomiting. It's becoming a little bit difficult to figure out who are the symptomatic and who are the asymptomatic patients. So.
Thank you both. I've got another question here. Does ARMA have a problem with the governor forbidding prophylactic hydroxychloroquine, overriding judgment of prescribing physicians? Dr. Goldberg?
I guess this is my turn. I will say this, is that like everyone else, we're following the evidence, and depending on what the evidence shows is where we take our positions. We are fortunate in that we do have an ear with the governor's office and with DHS with our weekly meetings. And we've referenced a couple of these executive orders. I can tell you that there's language in there that came pretty much from us. So when we have an issue with that things are not following evidence-based medicine, we will follow up and we discuss it with the relevant stakeholders, and we do get listened to. So we never go hard one way or another. We always have conversations because that evolves, and we will continue to do that and follow the literature and follow the data and use that to come up with well-based answers when we reach out to the governor and DHS and others on how to address all these issues, including treatment plans that are, as we've all been saying, constantly evolving and learning from. So that's pretty much going to be my sum answer to that.
Thank you, Dr. Goldberg. Next question from the live audience. Do we have to get COVID-19 PCR testing on patients without symptoms for procedures done in the office or an ASC?
My answer would be yes. If a patient's coming in for a procedure in an outpatient surgery center or a hospital, I think they need to be tested 3 or 4 days ahead of time and identify whether they are going to be at risk. For one, two things. We don't know how a patient with active COVID-19 is going to respond to a surgery, especially with the complications of hypercoagulability. There's so many things that we just don't know about. So we want to identify those patients to protect themselves, and not knowing what immunologic trigger is going to happen if they were to have surgery. We don't know that. The other is to protect the surgical staff. We don't want them exposed. If a patient comes in with active COVID-19 because you didn't test them, and your entire surgical staff for that room is exposed and come down with it, one by one, you're losing your ability to care for other patients. So it's imperative that they be tested at least 4 days ahead of time. And if you can get it done more rapidly, great. It does put some trauma surgeons at risk for trauma and not being able to test those patients, but it is imperative that those patients be tested.
Yep, and I would absolutely agree for both of the reasons that you listed. And an additional reason would be because of the amount of PPE that we have available still in this country. And so if you don't test patients, then we may end up seeing an uptick in the utilization of PPE. and that may be, unnecessary. So at this time, PPE still remains a concern in this nation. And so I think that testing is good for the patient and it's good for the team. And also, you don't want to have your employees feel as if you aren't taking their safety as a priority, because you may start losing employees as well. And I think that's important.
Thank you both. We'll jump to another question submitted prior to the beginning of tonight. Does your facility have adequate supply of remdesivir, now considered standard of care as per Dr. Fauci?
That would be a big no.
That would be a big no, but it's coming.
It's coming.
And it goes back to, it was just identified last week, the remdesivir, and there's many other viral agents had been previously identified because of in vitro experiments, but either they were too toxic or wouldn't work, and there's some others that are being done in Europe where it's kind of a triple aim with interferon or remdesivir and others. We don't know, but it's being released. They're improving, but at this very moment, I don't think anyone has it.
No, I think, so this is something that the federal as well as our local government is obtaining for these extremely ill patients. I don't think anyone has an exact protocol on who to use it on at this time, besides the very, very ill in the critical care unit. They're releasing it to hospitals, and I think they just obtained some. So DHS has some, but we're unsure of how much they have, but they'll be distributing it to the various hospitals at this time.
Yeah, this goes back to our earlier discussion of it. We're writing the book because if you really look at remdesivir and the action, theoretically it would appear that the sooner you use it, the better off you're going to be. But using it late, even though it's decreases, the time of the illness, it may completely reverse the illness if it were used immediately. These are all things we don't know. And it hasn't been studied. And like I said, I've learned more about the re-educated on the physiology and the pharmacology of antiviral agents. I didn't want any more about this and volatile gases, but here I am.
Medical student school all over again for us.
Yes.
Thank you both. Next question. In the event of a surge, which we're all hoping doesn't happen, but if it does, are institutions making arrangements for facilitated transfer of patients if capacity is met, or partnerships in the community to secure offsite space, et cetera?
And I would say absolutely yes, and this is something that we can thank the Arizona Department of Health Services for doing. They have been working extremely hard on this, and so there is something called the Arizona Surge Line. Many of you may have seen it, and so all COVID transfers are going through that line, and I can't remember the exact number. They said today how many transfers have gone through that line, and that's really to manage a surge load, so manage the patient load across all of the hospitals that have capability. So we're required daily, I think now it's every 4 hours, to submit how many beds we have open, how many ICU beds we have open, how many ventilators we have open, and when someone calls and needs to transfer a patient, we have to respond within 30 minutes, and people have done a fantastic job so we can move patients to areas where they are able to be taken care of. And I think this is just my opinion. I think this is the reason why the outcomes in this state are really, really good, because we have really competent healthcare facilities out there, and we are all willing to help take care of these patients.
Yeah, and the other thing that Dr. Chapatel mentioned earlier is recruiting physicians with past experience in different areas. I was laughing at when she mentioned about recruiting physicians. So I probably haven't taken care of a patient on a ventilator in 15 years, but I had to purchase a book on acute care, critical care medicine on managing a patient with ARDS on a ventilator to bring myself up to date because I volunteered to be an intensivist at our Chandler hospital. So all those things I think are being, every hospital in the state of Arizona, I believe, is trying to recruit and bring other physicians and providers up to date to help manage as well as the hospital capacity.
This
And
is
you
Libby.
should
I
know
would
that-
just,
Sorry.
oh, I'm sorry, Dr. Chapatel. I was just going to add one comment with regards to the surge line. We do know that ADHS, as you just said, has gotten this up and running. They are still actively looking for volunteers from the palliative care and critical care communities to help staff that. So if anyone is interested, please let us know, and we're happy to put you in touch with the right folks. And then the other thing I would mention, just in response to this particular question, is that we heard from DHS actually just yesterday that they are also looking at St. Luke's and preparing that as a facility if it's needed in the future. And that would be more of a step down, low acuity for patients that are recovering from COVID-19. But there are certainly plans across the state and within the community if a surge happens and we need additional capacity and resources.
Thank you all. We're going to close out with one final question here. Is your hospital or facility participating in the online match platform to swap of supplies? And are you aware of any hospitals in Arizona connected in such a way?
I don't know.
I mean, I do know that the Dignity hospitals are sharing with each other what they have and trying to make sure we're dividing that up. But I don't know for a fact, but I could pretty much guarantee if Banner had a plethora of something and Mayo Clinic or Dignity didn't have it but needed it, that it would be shared. I'm absolutely confident of that.
So I can tell you yes, now that I understood the question. We have been working in an unprecedented manner. So DHS is trying to submit and send information if a hospital is asking for gowns. We did get a request from somewhere up north that they were looking for gowns. And so they sent that around, and I think that we were able to send gowns. So it's informal right now. It's not right on our websites, but we have been collaborating.
Thanks, Damien. And I know that we are getting ready to wrap up, and so I will turn it back over to Damien to do so. But I just wanted to first say again, thank you so much to all of our panelists tonight. We're so honored to have the senior leadership from Dignity, Mayo, and Valleywise participating, and I think this session has been very informative for everyone that participated. So thank you again. Damien?
Yes, thank you, Libby. Then just here a quick recap for the town hall tonight. The town hall was recorded and will be published on ARMA's YouTube channel in the following days. If you have any further questions or concerns that you'd like addressed, we ask that you please do email us at communications@azmed.org. Resources that are available to you on ARMA's website. Quick reminder here for telemedicine, COVID-19 resources, an FAQ, as well as financial resources related to COVID-19. So with that being said, we'd like to thank everyone for joining us tonight. Thank you, Dr. Chapatel, Dr. Bethencourt, Dr. Goldberg. We hope everyone has a great evening.
Nice working with you. Thank you.
Good to see you guys.
Good night.